facilitating today's webinar.
Fantastic. Thanks so much, Di, and welcome everyone. I think, Marianne, can we get the slides up? And then I can just go through the agenda for the session. Thank you so much. So here we are, advancing global evidence on health inequality aversion. There we are. Yeah, that's fine. And here's the agenda. So basically, I'm just gonna, my role is just to keep time because we've got 4 fantastic presentations, which are very short and sharp. We're going to go through all the presentations one by one. We do actually have a tiny bit of time after each talk for a little bit of chit chat and questions if you want. And please put questions in the chat as we go. So we've got 4 countries where they've elicited inequality aversion using the same survey method. Marianne is going to take us through the survey method that we use called benefit trade-off. And then she's going to talk about Australia. Then we've got India, Japan, Uganda. And then a general conversation. And I'm really excited about this because a lot of different countries are now starting to consider using distributional cost effectiveness analysis, consider incorporating equity and health inequality concerns in a sort of quantitative way in health technology assessment, and maybe even in other things, in public health decisions and so on. So it's quite exciting, and a lot of countries are doing these surveys to find out how much the public care about this. It's very exciting, and we've got a great set of speakers. So I think I'm going to be quiet now and let Marianne get on with it. Any other housekeeping I need to mention? I don't think so. Just shove things in the chat and we'll have a good time at the end. Marianne, I'm going to hand over to you.
Thank you very much, Richard, and hi, everyone. I will start with an acknowledgement of country. So I would like to start by acknowledging the Wurundjeri people, who are the traditional custodians of the land on which I live and learn and on which this project was conducted. I would also like to pay my respect to the elders, both past and present, of the Kulin Nation, and extend that respect to any Indigenous Australian present with us today. So as Richard mentioned, I will go through an introduction, then present some evidence from Australia. In all countries, definite budgets are allocated to health, and health decision makers have to make the difficult decisions of dividing it to the best they can, knowing that investing more somewhere means investing less somewhere else. Economic evaluations are used to inform these decisions. It mainly looks at the additional benefits in terms of outcomes and the related costs, and then a bunch of other criteria such as severity, unmet needs, and equity is one of them, and that's what we will focus on today. So the equity principle will at times conflict with the efficiency principle, and there will be a potential trade-off between maximizing total health gain and reducing health inequalities. Decisions must be made on how much health benefits are we willing to forego to reduce health inequalities, and that reflects the health inequality aversion. Health-related social welfare functions can be used to quantify this trade-off and elicit health inequality aversion parameters, such as the Atkinson and Combe indices. It describes how social welfare is reduced by the level of health inequality across the population. This all started with Alan Williams' work on mapping the trade-offs between equity and efficiency in health outcomes, using a modified production possibility frontier to illustrate how different positions ranging from pure egalitarianism to pure efficiency reflect underlying social value judgments. Aki Tsuchiya, Paul Dolan, Richard Cookson, and others have advanced the field by looking at the characteristics of the health-related social welfare functions and empirically estimated societal preferences for trade-off between equity and efficiency. This paper here by Robson and colleagues elicited the health inequality aversion in the UK in 2017 using a benefit trade-off exercise. And several studies that will be presented today are adaptation of this paper to different contexts. I will start by introducing the benefit trade-off survey. So in this survey, we usually start by by selecting the equity relevant dimension. Here, for example, it is richest versus poorest fifth. Then we reflect the baseline health distribution, choosing certain health metrics. So here they are looking at the quality adjusted life expectancy, where the richest fifth have a quality adjusted life expectancy of 74 years, and the poorest a quality adjusted life expectancy of 62 years. And this is how the benefit trade-off looks like. So we have two programs, Program A and Program B, each having a different impact on different groups. The groups are on the x-axis, the quality adjusted life expectancy on the y-axis. So the richest fifth will have a quality adjusted life expectancy of 74 years, while the poorest fifth, a quality adjusted life expectancy of 62 years. So Program A will add 7 years to the life expectancy of the richest and 3 years to the quality adjusted life expectancy of the poorest. And that will give us a total gain of 10 years and a gap of 16 years. So 10, we did 7 plus 3. And then the gap between these quality adjusted life expectancy. And then Program B will add 3 years to the quality adjusted life expectancy of the richest fifth and 8 to that of the poorest fifth. And then participants are asked to pick which program they prefer. So do they prefer Program A, do they prefer Program B, or are Program A and Program B equally good? The question is framed as, imagine you need to choose between two large government programs. Which one would you choose? Respondents are usually also told that the programs have the same cost and impact the same number of people. And here we are also assuming that the middle 3/5 are not affected. So anything between the richest fifth and the poorest fifth, they're not impacted by this program. So participants are asked to answer a series of trade-offs where Program A usually stays the same and then Program B will differ. And then the sequence of responses obtained will be classified in 15 categories. So looking at the sequence of responses, for example, under health maximizers, B equals A, means that the participant preferred Program B in the first trade-off question. Then in the second trade-off question, both programs were equally good. And then in the last 5 trade-off questions, they preferred Program A. And this is the sequence of responses. So participants whose sequence of responses don't fit into one of these categories were not included in the analysis and deemed invalid. The first category here, the first 3 categories are pro-rich. So these are people who always prefer gains to the better off. The 4th category is the health maximizer. These are people who would like to maximize total population health gains over inequality reduction, so they don't have any concern for equity. Weighted prioritarian are the 7 next categories, so 5 to 11, and here they offer greater weight to the worse off. Maximin would be concerned only with improving health of the worse off. And the last 3 categories are egalitarian, and the egalitarians value reducing inequality so much that they are willing to sacrifice total health to benefit the worse off. So the benefit trade-off exercise measures the health inequality aversion by identifying the point at which a respondent will switch or will become indifferent between 2 programs. Health gains or losses at indifferent points are used to estimate each respondent's Atkinson parameters. And then the population median parameter is used to determine the population health inequality aversion. Here we have the distribution of the responses from the UK study. They used 244 valid responses, and the median parameter was 10.95. There are other methods that are used to elicit health inequality aversions, such as the person trade-off, level trade-off, and constrained resource allocation. Moving on to the evidence from Australia. So despite being a high-income country with a well-established national healthcare system, Australians face huge disparities and are expected to live less years depending on where they're born or who they're born to. Here we can see one example where there is an 8-year gap between the life expectancy at birth of Australian Indigenous and non-Indigenous, and disparities exist between other groups in the society as well. So based on this, the aim of this study was to elicit health inequality aversion parameters, the Atkinson and the Colm indices of the Australian public between 3 scenarios. So the first scenario that we looked at was income group, looking at richest fifth, poorest fifth, geographic group, comparing people living in major cities and those living in rural areas, and ethnic group, Indigenous Australians versus non-Indigenous Australians. So we had 3 separate sets of benefit trade-off questions. This is an example of the Indigenous status scenario. On the x-axis, we have 2 groups, Indigenous, non-Indigenous. Then on the y-axis, we have the life expectancy at birth. And this is the metric, the health metric that we chose for this study. And it's different from the Robson study where they used the quality adjusted life expectancy. We also have the boxes underneath showing the post-program health distribution, the total gain, and the gap, and we're asking respondents to select one program. Very similar to the previous one, but here we're looking at the geographic group task, comparing people living in major cities and those living in rural areas. And then the third task where the poorest and richest quintiles are being compared. So each task had 5 benefit trade-off questions, and only the valid responses were included in the analysis. This is the base case results slides. We conducted some sensitivity analysis, but I will not be talking about that today. It's all in the paper. Around 20% of the sample had invalid responses and were not included in the analysis. Here we can see the distribution of responses for each category after sample reweighting. I will go over this graph from the bottom up. So starting with income group, we can see that with the socioeconomic status that was defined by income, 43% of the respondents were weighted prioritarian, and these are the respondents who would value equity and are willing to trade off different levels of health gains in order to reduce health inequality. 11% were pro-rich, giving more importance to health gains to the richest, and around 43% were egalitarian, willing to level down total health gains in order to reduce inequalities in health. Only 2% were strict health maximizers. All they cared about is the cost and effectiveness with no concern to equity, and 3% were maximum. So we can say that more than 80% were willing to trade off some level of total health gain in order to reduce health inequality. We obtained an Atkinson parameter of 27.16 and a Colm parameter of 0.3, and the implied weight is 5.19. So the results imply that at initial levels of life expectancy at birth, incremental health gains to the poorest fifth of the population should be weighed around 5 times as highly as incremental health gains to the richest fifth. Now, when asked to trade off health gains and inequality between Indigenous individuals and non-Indigenous individuals, around 40% of the responses were weighted prioritarian, 14% were pro-non-Indigenous, 40% had egalitarian views, 2% were strict maximizers, and also 3% were maximum. So we can also see that the majority of the samples give some priority to equity, but not an exclusive one. And the results here imply that at initial levels of life expectancy at birth, incremental health gains to the Indigenous individual in the society should be weighed more than 6 times as highly as incremental health gains to the non-Indigenous individuals. And lastly, for the geographic remoteness, we also have a very similar distribution of responses, and these results imply that at initial levels of life expectancy at birth, incremental health gains to the individuals living in remote areas should be weighed a little bit less than 5 times as highly as incremental health gains to those living in urban areas. And this 50% mark here marks the median respondents that is reflecting the societal preference. So to put this into context, current HTA processes in Australia focus mainly on cost and efficiency. They do consider other factors, and equity is one of them. It is mentioned in the Pharmaceutical Benefit Advisory Committee guideline as a less readily quantifiable factor. And there was a recent HTA review in Australia with the recommendations touching on equity, but without really mentioning the inclusion of any quantitative method. The results of this study highlight the public's views on the importance of equity and indicate that to some extent the public would like to see equity incorporated in the decisions. And the results also provide researchers and policymakers with one of the building blocks of the distributional cost effectiveness analysis. And I would like to end with a quote from Bill Bryson's book. I was recently reading it, and this sentence was in one of the first chapters. Australians have a society that is instinctively egalitarian. And I think this study justifies, at least in part, this statement, with the vast majority of the public willing to sacrifice health gains in order to reduce health inequality. This QR code here is not for the book. It will take you to the paper if you're interested in reading it. Thank you very much for listening to me.
Fantastic, Marianne. And you get extra bonus points. You finished with 1 minute to spare.
That's good.
So well done. And also, I have to say, I mean, so everyone, Marianne is a PhD student. I thought that was a very beautifully clear lecture on the benefit trade-off approach to inequality aversion. Much better than I could have done it. And I like the way you set things out. So well done, Marianne. I think a good example there of how to give a short talk. So thank you. I'm hoping, I mean, so we don't actually have any questions in the chat. Please do shove things in the chat. No question is too dumb for us, right? In fact, dumb questions are usually the best questions because they force us to think and put a different perspective on things. When I say dumb, I mean simple, naive. You know, you don't have to be an expert in this. So do shove in questions just to get us talking. Now, we've scheduled 3 minutes if we wanted to for chat. Di, am I right that people are muted at the moment, but they will be allowed to speak at the end? Is that the way it works?
People can unmute themselves at any stage.
Fantastic.
So they can ask questions.
Super. That's really
just
flexible.
A request.
Thank you. Well, that's absolutely super. So, you know, if anyone wants to ask a question now, you know, it's always nicer to hear someone's voice. You can either shove it in the chat or just shout out. But if you want, you know, you might want to zoom on because we might want to zoom on. Now we've got a hand up from Tori. Do you want to say something, Tori?
If I can manage to unmute, can I be heard okay?
Yes, well done. Yeah.
First of all, thanks, Marianne, for such a great presentation. It's such a clear way to portray some really important and complex concepts. I was just wondering, like, what more do you think it would take to sort of formalize policy around including some of these equity-based sort of considerations for decision making, like within Australia? Like, I don't know whether other countries have, you know, in more formally incorporated equity considerations in their HTA decision making, and what sort of evidence led to that change, if that makes sense.
Yeah, thank you very much, Tori, for this question. And so I think that generating more evidence, so the more evidence we're generating, the more we know about the topic, the more we know about the challenges and the limitation, but also the strength. So by generating this in a few countries, it gave us a lot of perspective on this. And so I think in order to be included in policy making in Australia, from the last HTA review, my feeling was like they want more evidence generated. So, for example, distributional cost effectiveness based in Australia to show them what's the impact of including this. So how will this change what we already have?
Right. Okay. And how will it change in terms of total health gains from including more equity considerations, or?
Well, let me say something there. It'll reduce the total health gains because the whole point is you're making a trade-off. So there is a sacrifice to the total. And you end up implicitly or explicitly having a set of weights where you put more priority on the health. Improving the health of indigenous people would get a higher weight, and so you would be sacrificing some total gain for reducing inequality. But I mean, it's a really great question, and in a way, I'm sure we'll come back to this for other countries as well, because it's so important. How in practice can you use it? And I could say something about the England case where we're starting to look at this now. But I'm just remembering time-wise, we did have a long introduction session, so I think actually we should move on to the next talk. But thank you so much, Marianne. Thank you so much, Tori, for kicking us off with a great question. And folks, do shove things in the chat as we go. So now, next up, we've got India and Professor Sitanshu. Please take it away, 6 minutes.
Yeah, thank you, Richard. Just to check, can you hear me well?
Lovely.
Yeah, thank you, everyone. And it's a nice opportunity to share what we have done in India regarding this particular issue, a very complex issue. And thank you, Marianne, for setting the stage. It was very nice that you have explained.
Oh.
The methods, so spend time in them. I'm from Puducherry, so that's why it is located to that. So can we go to the next slide, please? Yeah, so we started this particular, next please, you can go ahead, front. Yeah, so the objective of this particular survey is to elicit the level of health inequality aversion in the districts of Puducherry and to estimate the health-related social welfare function. We can go back, please. Yeah, so to address this objective, we had a mixed method design where we have a quantitative component and a qualitative component, where the quantitative component is the survey that we conducted that was just discussed, and qualitative, we wanted to understand what people feel about it, about the survey. Is it cognitive load is okay, or are they able to understand the scenarios? The next slide, please. So before we started the survey, we did the report analysis of all HTA studies in India, where the equity work in India in our HTA ecosystem is just starting to get traction, where people are doing subgroup analysis and the other things. But we have not gone into estimating the health inequality aversion parameter, or now the current situation is people are thinking about it and how do we take it forward. So having done the report analysis, we did an extensive pilot of methods, whether this method is going to work in our setting. We started with healthcare providers and also moved to general population to see how these things are taken into the consideration and how they are answering these questions. So the main survey that we did was a face-to-face interview using the same methodology that Marianne just explained, and but we did some modification to the methods. Next, please. So the modification was when we did face-to-face interview. In many cases, it was online interviews. There was a video component that was there in other countries' survey, but we did not have this video component because during our pilot, people got confused about this particular issue. So we did not have the video component. There were priming questions, and the main policy questions came later on. Next, please. So what we did in the overall survey is we interviewed 10 people, but the eligible responses were 609. The age group was in the productive age group. Around 60% were females, and 70% stayed in urban area, and they were educated up to different levels as mentioned. So next, please. So the results that what we got is similar to the description that Marianne gave. You can go ahead, Marianne, please complete that. So we divided it into pro-rich, weighted prioritarian, health maximizer, maximin egalitarian. But the median level, which is important to calculate the social welfare index, is we got in the range of egalitarian. That means, as if you look at the literature beyond weighted prioritarian, which is maximin egalitarian, it is difficult to calculate the Atkinson's and Colm. So we could not calculate. What it means is our population is strictly preferring to reduce health inequality so much that they're willing to sacrifice the potential health benefits to the worst of. So that's the population's response that we got in our survey. Going to the next part, please. And we also wanted to look at the urban and rural distribution, male and female distribution, whether there is a difference in the responses that we got. So the median responses was found to be in the egalitarian zone, and there was no difference between male and female and the area of residence that we have looked at. So around 85.2% of the participants were willing to trade off some total health in order to reduce health inequality. We could not calculate the health-related social welfare function because the median response that we got is in the egalitarian zone. Next, please. We also looked at the qualitative component where we tried to we did around 15 in-depth interviews where we looked at fairness, inequality, and survey methods as the question. The major findings that we found was some people responded it was not very easy to understand the questions. When we go from 7 scenarios, it was difficult.
1 minute warning, Sitanshu. Sorry.
Yeah, and I'm about to finish. Yeah, and specific examples probably add in understanding. So we are in the process of starting this survey, and an attempt that was made. We are trying to see how do we present it to the group and try to understand. So my last slide is on acknowledgement. All this learning that has happened is over a period of last 3 years for all the HTA Asia Link network and this conferences. We have done workshops together. Many people are here, Marianne, Kyoko, Richard, and also HiTab group. So that's what the learning. So I would like to dedicate my learning to them, and I'm still learning in this process. I'll stop here. Over to you, Richard. Thank you.
Thank you so much, Sitanshu. I didn't even need to give you the warning. You were bang on time. Well done. Well done. Thank you. So fascinating findings, quite different from the Australian and the UK context with such a higher proportion of strict egalitarian. I'm going to abuse my position. I'm just going to ask a quick question now and then move on because I don't think we have time for general questions. But just, did you look at education as a possible? Because it seems to me that people maybe aren't fully understanding the maxi-min. The fact, they're not only not caring about helping the rich, right? Zero value on improvements in health for the rich, but they're even willing to sacrifice health for the poor if the gap goes down, leveling down. And I just wondered, with it, did you look at postgraduate versus non?
Yes, we are going to do that after having got that comment from you, Richard. So we're going to analyze it again to look at whether postgraduate versus others have got a different way of interpreting the findings.
Yeah, because I think that's a very general issue about how well people understand these questions with different levels of education. And I did notice that in the rural, you got slightly higher proportion. So that's a possible. I don't know. Anyway, Sitanshu, thank you so much. That's really great. I'm going to move us on now. So we're zooming around the world at great rapidity, and we're going to Japan next. Kyoko, are you ready?
Yes, thank you very much. I hope
Go
you
for
could
it.
hear
6
me well.
minutes for you.
Yeah, thank you very much. I'm pleased to have this opportunity, and thank you very much for the organizer to present my research, Health Inequality Aversion in Japan. This is a mixed method study at Keio University and University of York. Next, please. I start with my sincere acknowledgement to my co-authors, advisors, and research collaborators, Richard, Tim, Aki, Matthew, and Noriko. And I also acknowledge research networks and funding. And there are 2 main references of this presentation. My quantitative study is in Press Online, and my mixed method interview study will be presented at the upcoming ESG Summer Conference, and abstract is in Press. Next, please. So the background about the health equity in Japan and East Asia. So health and socioeconomic gaps are increasingly recognized in Japan at the policy and political level. And health equity is a term that does not exist in the Japanese language. I translate it as fairness in health. And in Japan, there are variations in the conceptualization of fairness in health, yet with a general implication of equal distributions as fair. And in East Asia, health equity considerations in HTA are increasingly recognized, yet this is still limited as published by Patikon et al. And I acknowledge my team and my co-authors. Next, please. So here are my method, mixed methods. Phase 1 was a self-completed online survey, and this was a replication of Robson et al. Yet changes were made regarding baseline healthy life expectancy, and quota sampling by social demographics from a survey panel was employed. My phase 2 was a mixed method individual interview study, and online interviews were conducted by myself taking 34 samples and another by the rest. And quota sampling was again employed. And this interview comprised quantitative interviews using the original questionnaire and the qualitative interviews, including reasons of choice, values, and beliefs. Next, please. So here are examples of the benefit trade-off tasks. And to the left, this is the introductory graph from the UK study by Robson. And to the right, this is the first BTL task in the Japanese study. So baseline healthy life years is 79 years for the richest fifths and 69 years for the poorest fifths. Next, please. So here are results of descriptive key categories. And the upper figure is showing the distribution, including inconsistent and invalid responses. So valid consistent response rates were 76% from the interview and 36% from the self-completed survey. And to the bottom, this is the distribution of the key main categories. And there are some differences in that the proportion of weighted prioritarian was much higher and egalitarian was much lower from the interview study compared to self-completed online survey. Next, please. So this is a result of inequality aversion parameter values. A median from the Japanese studies were weighted prioritarian, and this was also similar to the UK results. And here are the Atkinson and column parameter values, and these suggest substantial concern for health inequality, which at current levels of healthy life years implies weighting health gains to the poorest fifths of people in society 2 to 7 times as highly as health gains to the richest fifths. Next, please. And here are results from the mixed method analysis. First, we noted inconsistent response and reasoning across one BTO choice to the next. And this was observed by a quarter of the survey sample. And these respondents were mostly unaware of one's inconsistency. And second, indecisive choices and reasoning were mostly explained, and among those who have chosen at least one indifference. And third, self-interested motivations were reported by a third, despite the exercise using a social perspective. And fourth, recognition of more tax contributions by the rich were also reported by a third, and this was a majority of inequality-seeking respondents. So this suggests the violation of the standard BTO approaches assumption as a concern. Next, please. So here are challenges and future research for discussion with our presenters and also with everyone who are joining, please. So regarding the conceptual issue, as mentioned, the health equity is a non-existent term in Japanese language, and this is also the case with other contexts, in some contexts. And regarding the graph reading, it did not seem to be a problem in Japan. And regarding the recruitment, there was selection bias because we used an online survey panel in my survey. And regarding the comprehensions, assumptions by the respondents were reported. And for example, tax contribution of the rich, and another was a blaming of assumed unhealthy behaviors among the poor. And I also mentioned that organization of one's opinion in a coherent, consistent manner was a challenge in my Japanese study. So thank you very much, and I look forward to our discussions.
Yuka, fantastic. Literally, well, with 6 seconds before time. Well done. Congratulations. Great talk. I'm going to move us straight on, just looking at the time because of the thing. So let's get on straight away to Kenneth, and then we can have a good long session at the end for conversation. So thanks so much, Kyoko. Kenneth, are you ready? We're going to Uganda now. Are you ready?
Yes, I'm ready.
Brilliant. Off you go.
Yes, thank you very much. My name is Kenneth Katumba. I'm a PhD student at the London School of Hygiene and Tropical Medicine, Bioeconomics. I'm also a health economist at the MRC UVRI unit in Uganda. And I'm presenting, next slide, please. I'm presenting on behalf of a very large team, but I would like to mention my co-PIs. That's Dr. Fan Yang and Dr. Susan Griffin, who are based at the Center of Health Economics at the University of York. So my task today is to give a brief overview of developing inequality aversion parameter for Uganda. Next slide, please. And as we started to do this work, we had some concerns, and Mary and the rest of my co-presenters have given a very good introduction to why we are concerned with inequality in resource allocation. But in Uganda specifically, our two objectives were, one, to estimate the inequality aversion parameter as the first one, but the second, at the time, it was the first study that we're doing to do this work in a setting similar to ours, a resource-constrained setting. So we wanted to see if the methods that were used in high-income countries were feasible in our setting. So our concern, we kept it simple. We wanted to look at inequality comparing the richer versus the poorer Ugandans, and wanted to know, do Ugandans value health gains among the rich and the poor people equally? Next slide, please. So a brief overview of the methods that we used. We adopted a survey from the UK study, and this adoption included translation. We also used the video, the video explainer, and we also developed a video that was locally adapted. So it was adopted in terms of the images of the people in the video, in terms of the names, but also the language. Then our survey, the way we structured our survey, we started off with instructions for the interviewers, very heavy instructions. Then we had some country-specific questions like the sex, the age, education. And then the first set of country-specific questions was used sort of to determine a representative sample for Uganda, because Uganda is very diverse in terms of the population and characteristics. Then after that, we administered the EQ5D5L, and after that, we had an inequality survey in terms of the introduction to the survey, the trade-off questions, an animated video that was adopted as earlier presented, and then the trade-off questions. Then after that, again, we had more country-specific questions, which were more or less the demographics. Next slide, please. So this is what the screenshots from our video look like. So as you can see, the names were totally locally adopted, even the skin tone, but also it was in Luganda, which is the language that's spoken by majority of Ugandans. We have more than 50 languages, but Luganda is the one that most people speak. Yeah, next slide, please. So also we paid attention. Well, I may not go into detail for this slide. I wanted to show that we paid attention to have the demographics, so a sample as representative of the general Ugandan population as much as possible. And about 87% were female, and about 52% were female, and 47% were male. Next slide, please. In terms of the results from the parameter, what came out very clearly is that majority of the Ugandans were pro-poor, with about 79.4% being pro-poor. Even the median was lay in the pro-poor, and only about 1% were perfectly egalitarian. Next slide, please. So yes, so I think what I thought was important to bring out is what we saw clearly in terms of lessons was that the Ugandans generally value health gains for the poorer people. With our estimate was that incremental health gains to the 20% poorest Ugandans would be valued at about 6 times compared to the gains to the richest 20% of the Ugandans. And also another thing that we saw is what we did a lot of is thorough validation of the survey was necessary. And this is also linked to some of the challenges we faced. One of the biggest challenges we faced was COVID-19. So we had to do a lot of training and retraining because initially in the pilots, we realized that some of the responses were being affected by the experiences of COVID-19. So we did a lot of training and retraining of the interviewers and a lot of validation in terms of the survey. Also, it's very similar to the Japan study. Some concepts were alien to the setting, like trade-off. You know, it was very hard to translate, and also inequality. So it was a challenge to have this in the local context and for the people to understand in the survey to be able to give valid responses. And in addition, in our setting, illiteracy was still a challenge. We had a high rate of a relatively high rate of illiteracy. And like I mentioned before, Uganda is very, very diverse. But from our study, we had valid responses, we had good results, and our findings and our recommendation is that locally adopted surveys can work in other settings if the researchers or the people who are doing the adoption do a thorough adoption pre-carrying out the survey. And we also think and recommend that inequality impact using these quantitative methods can be very successfully integrated for resource allocation in limited settings as well as in high income settings. Thank you very much.
Okay, fantastic. Thank you. Bang on time. Well done. And very interesting, interesting differences in the findings. We're kind of done for this in terms of speaker time, but I'm very happy if people, since we're in the general summit, if someone just wants to reflect on Kenneth's talk there, does anyone have a specific question for Kenneth now, or should we go into the comparative? I'm not seeing any immediate hands up. I mean, let me kick us off with a general comparative. So we're now into the general session. So thank you, speakers, for fantastic 4 talks. Let's think about comparisons between the countries and how we move this forward, and then the policy. I'm getting some claps there from Tora. Yeah, I applaud you all. Thank you. Well done, guys. So a general question for you, Kenneth. I mean, why do you? My feeling is your findings were a bit less pro-poor, a bit less extreme certainly than in India. And yeah, it can actually come in. Yes, if we go to that, am I right that your median was pro-poor 5? Was not number 9 there? Was it? Yeah, you're still muted, Kenneth. Sorry.
I was muted. The median was pro-poor 7, number 11.
Oh, it was all the way down. Okay, which is
Yes.
what we often find. Okay, yeah, okay, fine. So was your sense that your findings in terms of the categories? I mean, the actual. So one thing about these studies, the actual inequality aversion parameter depends very much on the baseline health, and there's a big framing effect going on there. So we no longer pay too much attention to people's preferences are not very precise. This is a very complicated, challenging area. But we're interested in the categories. We do think that high, low, medium levels of inequality aversion, we can compare between countries. And so what's my question? I'm trying to formulate a question here. Do you think that your findings in Uganda are kind of similar to the UK and to Australia, but they're a bit less strongly pro-poor than in India? Would that I mean, is that a fair summary?
I think our findings were more similar to the Australian results. Because from the presentation that Marie made, also Australia was, and with a very good summary at the end that Australians are inherently egalitarian. So I think we lie more or less on the similar side.
Yeah, and did you manage to did you look at differences in views by education and wealth and so on, the subgroup analysis?
We did not dwell a lot on the subgroup analysis, but I think we were limited, and I think this was a missed opportunity for us, partly limited by the way we carried out the study, because we carried out the study at the same time we were estimating the EQ5D, 5L.
Okay, you were busy.
Yeah.
So there is data. So if
Yes.
PhD students are floating around, if they want to do a quick
So
and easy...
I think the data is there. We had the data on the education, we had the data on income, the sex, but we did not delve very much into it.
Okay.
But because also our focus was on, can this work in this setting? And can this work was mostly looking at only the wealth category. So I think it would be an interesting missed opportunity.
So in principle, would you imagine there's a bright young MSc or PhD student who wants to do a quick, would you share your data and allow them to have a look at it?
Yes, I think definitely.
That would be a fun little study, because I think in general, people find that it's not as strong as you might expect, that poorer people are not much more likely to be pro-poor than richer people, but a bit more. And certainly we do find by education, more educated people, I think in general, tend to be less strict egalitarian. Anyway, so I think that's quite an interesting thing to do. All right, so yeah, absolutely. I should stop talking now. Marianne, and please, people, do put your hands up or put questions in the chat for everyone. Marianne.
I would like to ask a question to Kenneth. Thank you very much, Kenneth, for this very clear presentation. One thing that caught my attention is that I think you're the only country who has zero pro-rich. Between all of the other countries, so all of the countries that we saw today and the other ones that were done, I don't think anyone has a zero pro-rich. So that was very interesting. And my question is was around invalid responses. So you conducted this in person, didn't you, face-to-face? Yeah, and did you have any invalid sequences or invalid responses that you had to discard?
Yes, we did have invalid responses. I was trying to get the frequency of the invalid response. I don't have them of it, but we had some invalid responses.
You did, okay.
So I'm just thinking out loud, and I'm wondering if the level of having pro-poor or rich would depend also on the level of inequality, income inequality, because we're looking at pro-poor and pro-rich in the country. So if it depend on the level of income inequality in the country, but also the social acceptability of this inequality. So maybe even if there are people who would want to be pro-poor, maybe in deep down, because of the deep inequality, deep-rooted inequality, maybe their responses would be swung towards being egalitarian or pro-poor.
We're starting to get some questions now, so I'll move on. I mean, you didn't have many rich people in your sample, Kenneth. That's another thing I noticed. So maybe it's partly the social demographics. So I think that I'll go to the online. So I'll go to Chitawan first, and I'll come to you, Trudy. You're very patient with your hand up. So Chitawan, do you want to say your question to us?
Yeah, hello everyone, and thank you so much for a very nice presentation. And I think actually Dr. Sitanshu already answered my question as well. So yeah, the question to Dr. Sitanshu is that about the pilot group that that India choose to pilot with healthcare professional, but because in Thailand we also pilot the survey with other group of people, including policymakers, patient representative, and others as well. So yeah, I just want to know whether there's any reasons behind piloting with the group of healthcare professional. And maybe to add on that, would you expect the different results from different group of people? Yes, thank you.
Yeah, that's interesting. I don't know. Sitanshu, do you want to say something that particularly the latter question? Why would they differ?
So thank you, Chetavan, for that. We did it because of convenience, because I work in a medical college. And when we did that, the first thing was to look at the cognitive load for this set of survey that we're going to do. This was difficult. This was a little complex. So we wanted to see if our healthcare providers are able to understand this. If they are not able to understand, then definitely it will be difficult for the general population. So that was the assumption that we had. Regarding your second question of involving policymakers and other things, I think that's a great idea. We should try to do this, but finding time for policymakers in our context was little challenging. And the third point is regarding will the response differ? I think it will differ definitely, because people who are working in healthcare setting will have a little more different viewpoint compared to when it comes to the community or the general public. That's what I feel, but probably Richard will be able to give some more ideas and insight into this question. Over to you, Richard.
Well, just before Trudy, I mean, usually doctors have less health inequality, less likely to be strict egalitarian, but maybe that's because they're more educated and they understand the questions better. So I think it's very difficult to disentangle the education level, the level of understanding from the views. And I really do suspect that a GP working in a primary care doctor working in a deprived setting might have a different approach than a very wealthy hospital consultant doing lots of private. I mean, who knows? I'm very prejudiced, but I imagine you'll get a spectrum of views, and that would be quite interesting to see. And it's a very big question. The views of experts versus the views of the public might differ here, and that's very important to tease out. Sorry, Trudy, over to you. And please unmute yourself. I think you've been muted by...
There we go.
Yes.
Thank you. Thanks. I guess I'm following on from that conversation, really. If we're wanting to get representative sample to do the survey to see the extent of inequality, it may mean that we need to have a mixture of online and face-to-face for those that are difficult to reach. But then you can see that preferences or their decisions differ, and maybe on their mode, which is kind of worrying. So I don't know which one is right. I mean, how do we know that? But there could be something because of that mode of delivery, but we've got to be able to do that if we want to be able to reach people, for example, who have not got the technology or the computers or the internet to do it online. So that was just really a comment, though I did wonder if there's been any work done on retesting, like asking people and then asking sometime later what their preferences are again. Again, it's not necessarily good because it might mean now they know what they're doing and they've had time to think about it. I don't know if that's a good thing or a bad thing. So that was just one thing. My other comment was, and I think I might have mentioned it before, if we are going to operationalize this within making decisions, how do you cope with the crossover or potential overlap? And I could definitely see this in the New Zealand context between income, ethnicity, and rurality, for example. And so if a population group is going to be covered within those three aspects, is that like triple counting? How are you going to accommodate that in the decision-making process? Just thought I'd leave a, easy question for the end there. Thank you.
I'm going to pass on that one.
Thank you, everyone. It was great. They were wonderful presentations. Thanks very much.
Judy, thank you. Yeah, very difficult one. Maybe that's a question for you, Marianne, about the three different dimensions.
Yes, and this is a question that we get asked a lot, and we tried to think through a lot. So what we've done are separate, and as you said, using the three would be double counting, and I don't think that is the right way to do. Yeah, I don't have a really clear answer. The only thing that I'm thinking about is there is one study who tried to look at income and ethnicity, and that, well, they solved part of the problem, but then incorporating a third dimension would be difficult. So they did that by categorizing the population into 5 ethnicity group and 5 income group, and then getting the better off and worse off of this pool. Yeah, I guess maybe the other way of doing it, and I don't know if Richard would agree, would be looking at the pure health inequality aversion, so not looking at any specific dimension, but yeah.
Yeah, well, there's all sorts of approaches, and ultimately it's a decision maker has to decide what are they most concerned about. Let's move on if that's okay. Lisa's got your hand up. Lisa.
Yeah, thanks. So I think first of all, it's fascinating set of research, and it's a real strength to have the same or very similar questions being posed. I'd strongly encourage as many groups as possible to do a mixed methods approach so that we can see if those explanations for choice behavior is common across groups. It's almost impossible to tease out social desirability bias from sort of retrospective explanations of the decisions you've just made. And I'm now just thoroughly intrigued by Trudy's idea of what if we actually do it as a development activity? So you get people to do it, and then once they've thought about it, you go back to them again and get some get a second round. So how do people? Because I think one of the things we find when we ask people about preferences in general is that they're actually not formed in people's heads like they are in theory, and that when you ask people a preference question, whether it's a time trade-off or a willingness to pay, what you get is people are forming their preferences in answering these questions. And I think it would be fascinating to have a program of research, Trudy, that where we go back and see how they build over time. But it's really interesting. I cannot for the life of me explain the India results, so that would be really interesting to probe further, probably with different groups. But there seems to be a really strong commonality of, as Kyoto says, of diversity. People are diverse, and they are diverse. And Marianne's results show Australia's very complicated, basically egalitarian, but also a bit racist, and they're very mix of differences. And I think for that reason, you're absolutely right, Marianne. You have to express difference in different ways because you get a little bit of variation that way. I think this is definitely the start of a very interesting international program of research. And Richard, we'll just leave the operationalization of it over to you. You just
no. I want these young, clever people coming in and sorting it all out. So I've done my bit. Thank you, Lisa. Very good. Yeah, I absolutely agree. And I'm very much in favor of these citizens jury approaches where you do it once, you feed back the policy implications, reflect what would this really mean for decision making, and then have a further discussion about it. Look, we're sort of running out of time. I've almost run out of time. Does any of the panel want to say a very quick final word before we finish? Or are we good? Sudhanshu, you're okay? Marianne, you should say a final word. Well, yeah.
Well, I'm happy to. Thank you very much, Richard. I would like to thank everyone who put in time to prepare and present, and thank you for those who took the time to listen to us as well. And thank you very much for all your comments. It gives all of us lots of ideas that hopefully we will all together work on putting in practice. So thank you very much, everyone, for attending. And thank you very much, Richard and Di, for sharing and
thank you all.
us.
Thanks so much, Maria. Thank you everyone for attending. That was a great seminar. I really enjoyed it.